Good afternoon. My name is Dawn Sybrandt. I'm the program manager too for nursing facilities, ICF, IIDs, and school-based services in Medicaid and long-term care with Department of Health and Human Services. This is a recording that I'm doing because we experienced technical difficulties at the last presentation to community-based DD providers. And this is focusing on specialized add-on services in nursing facilities as it relates to level 2 PASRRs for folks with intellectual disabilities and related conditions. These are the presentation objectives. Basically, we're just going to go through some history on PASRR, talk about specialized add-on services, see what's available, and then a very high-level overview of prior authorizations and fee-for-service claiming. I included this slide just so that people would know where to find Chapter 12. Our Chapter 12 resides at 471 Nebraska Administrative Code. 12-006 are the PASRR requirements, and 12-008 are the specialized add-on service requirements. These are not all of the sections of Chapter 12, but I did mention some of the more important ones just for information's sake. This presentation focuses on individuals identified with intellectual disabilities or related condition. You will see serious mental illness mentioned throughout. However, our specialized add-on services do not include that particular population, since we have an array of outside services in place for the serious mental illness population as it relates to the definition in the pre-admission screening and resident review regulations. So just a brief history. PASRR was established in 1987. It's part of the Omnibus Budget Reconciliation Act. All states were mandated to create a PASRR system, and by January 1 of 1989, they were required to have those programs up and running. There is a 3-year gap between that requirement, January 1 of 89 to November of 92, when the PASRR final rule was issued. Because of that 3-year gap, there are a lot of differences from state to state on how these are handled. And I just referenced the Olmstead ruling because that is important to keep in mind when we are looking at folks with disabilities and assisting them to live in the most integrated setting possible. In Nebraska, we use an outside vendor for all PASRR activities. As of January 1st, 2021, Nebraska uses KEPRO. And Medicaid, we have oversight of the PASRR program. The Division of Behavioral Health is responsible for contract management, billing, and general PASRR-related education. And developmental disabilities, that division provides expertise. So federal law requires any resident entering a Medicaid certified facility to have a valid PASRR. It's really, really important. Forgive me if I repeat it a few times, but there really should never be an individual that enters a Medicaid certified facility without a PASRR in place, regardless of payer source. So you will see the acronyms SMI, ID, and RC. Though basically serious mental illness, intellectual disability, or related condition. Every state has to have a PASRR compliant program in their Medicaid state plan, and Nebraska does. So there's 2 types of assessments, quote unquote. Every PASRR starts with a level 1. Level 1 PASRRs are a screening. They are only a screening tool. And basically what that level 1 is screening for are any individuals suspected or known to have either ID, RC, or SMI. There are several categorical exemptions. Basically, those are for when the provider that's submitting that level 1 screen is pretty sure they will escalate to a level 2. And so the categorical exemption allows admission based on that exemption for a certain period of time before requiring a new level 1 that will most likely escalate to a level 2. It is quick, it's online. Our vendor has specific software, and you can typically receive an answer in less than a minute once you answer all the questions. Level 2 PASRRs are an evaluation. They are in-depth. They're typically face-to-face. However, with COVID in March of 20, that all changed. We will see some time-limited ones. A lot of the ones I see are, basically 90 days or 180 days. Those are the two most common. The PASRR vendor is responsible for determining the need for specialized add-on services and what those, which of those services there should be. There is a dementia exclusion in PASRR. If there's a primary diagnosis of dementia, that will negate the need for a level 2 evaluation. Sometimes it's caught early and it's just done as part of what we call a level 1 clinical review. Sometimes it's not caught quite that early. The current contract for PASRR basically requires our vendor to go ahead with the nursing facility level of care determination, even if the dementia comes out later. They still do the nursing facility level of care eval. And you can find dementia exclusion regs at 42 Code of Federal Regulations 483.102. So here's where we start getting into specialized services. They've been required since 1992. They are a supplement to the nursing facility services. They are not provided by the nursing facility, and they're very specific to the individual's diagnoses, which makes them very individualized. These services only pertain to individuals who receive a full level 2 evaluation. This is federally required, so the identified services need to be provided, which means the nursing facility, they need to arrange for or provide them at their own expense or discharge. The purpose of this particular service that we're talking about is so that the nursing facility can partner with the community-based developmental disabilities providers. So again, very important, these services are not provided or billed by the nursing facility. They'll need to partner with community-based providers such as yourselves, and the community-based provider is the one that will do the specialized add-on services. So the next two slides contain the definition of specialized add-on services. The keywords are continuous and aggressive, consistent implementation for gaining skills or preventing loss of skills. Just as a little bit of background, when we were writing this particular state plan amendment to add these services, which are federally required, we just weren't making as good a progress as we had hoped. So because the two of us that were writing these came from a background of surveying ICF IIDs, essentially we took off our Medicaid hat, we put on our surveyor hats, and we started making progress with our state plan amendment once we started looking at it as an active treatment component. And so these services are very similar and rise to the level of training that exists in the ICF IIDs. Specialized services would not be recommended for an individual with IDRC who does not have needs in the areas of activities of daily living, social skills, communication skills, etc. It is possible to have someone with IDRC diagnoses that meet the criteria for the level 2 without requiring the ongoing aggressive training to increase the skill deficits. In the IDRC world, it does require a significant IQ impairment and deficits in adaptive behaviors that occur prior to age 22 during the developmental stages. Therefore, if you have someone who has a traumatic brain injury, if that did not occur prior to age 22, then they wouldn't fit in this definition. So as long as a traumatic brain injury occurs prior to 22 years of age, then they can qualify as ID. Related conditions, boy, there's a whole host of them. KEPRO, when people are completing those level 1s, they have a very lengthy list of different kinds of related conditions, everything from cerebral palsy, epilepsy, even traumatic brain injury, Prader-Willi, just all kinds of different things to choose from. They also have a choice for other, because of course it's not an all-inclusive list. So the identification criteria, again, prior to age 22, there needs to be substantial limitations in 3 or more of these 6 major life activities. And again, our vendor, who is KEPRO, is responsible for making these determinations. And here's like a list of all of the examples of related conditions. These are what are on KEPRO's level 1 PASRR screening form, but it's definitely should not be considered an exhaustive list. I have this in here because essentially it should be noted that an accurate PASRR level 2 evaluation, it is the responsibility of everybody involved in the process. Nursing facilities need to inform the PASRR vendor when there is evidence of an outside agency providing DD services to someone entering the facility, even in the absence of like a specific diagnosis. In addition, if you as a DD provider have an individual that requires surgery and rehab and goes to a nursing facility temporarily, you're responsible for ensuring that that intellectual disability or related condition is identified in that PASRR, and if there are training needs for that individual, that these needs are identified in the level 2 PASRR. It's very important to remember these specific services are related to individuals with intellectual disabilities or related condition. Again, we did not include serious mental illness in this SPA, and the keywords are continuous and aggressive. So when recommended by the PASRR vendor, these particular services need to be prior authorized through our unit here in Medicaid, and they'll need to rise to that level of services similar to active treatment in the ICF IIDs. These are the 5 services. It's really 4 services plus basically mileage. And we'll go through those more in depth as we move along. Habilitative skills training, it identifies skills needed in areas such as dressing, laundry, bathing, communication, personal hygiene, basically pretty much anything for your everyday living, things that you need to be able to do to function. There is a definite, what we refer to as active treatment loop. The PASRR will identify the skills that might be needed, and then it's up to that outside provider to develop and implement formal training goals related to those identified skill needs in the level 2, and then also to monitor and revise goals according to that person's response to training. And this is very similar to what the IDT does for an individual in a community-based program. And basically it's a team effort. And there are limitations for each of the 4 services that are built into the service. These are straight out of Chapter 12, so they're all right here, but by all means, please refer to Chapter 12 if you are so inclined. Transportation's not included. It has to be authorized and billed separately. Habilitative skills training cannot be provided during the same time as habilitative community inclusion, employment assistance, or employment support. And that third bullet is basically a standard disclaimer, if you will, regarding services that can't be provided during like normal school hours if you have someone that you're working with that's under the age of 22. Community inclusion, habilitative community inclusion. This is similar to habilitative skills training, but basically we're identifying the needed skills to develop and implement training and then monitor and revise goals that would help that person be a part of their community, to establish relationships in the community. It's really important to note that this particular service has to be provided in the community. Unlike habilitative skills training, which could be provided in the community, but most likely might be provided in the nursing facility. This particular service has to be provided in the community. And again, you have your, what I call the active treatment loop, identify the skills. Those are actually in the PASRR, develop and implement the formal training, and then monitor and revise as you move along. So habilitative, these are your standard disclaimers. Transportation's not involved or included in the rate. Again, can't be provided during regular school hours for any school-aged children, and it is not meant to supplement or replace activities that are otherwise part of your normal nursing facility activities program. These are above and beyond. They're related to the person's community that they came from and maybe going back to, etc. So employment assistance focuses on the vocational aspect of the individual's life. Same assessment and skill building loop to identify and assess, develop and implement, and then monitor and revise. It's geared toward helping the individual explore their preferences and acquire skills necessary to go out and find and obtain a job. So it could be resume development, interviewing skills, job search, etc. It can be provided at the nursing facility or out in the community. Standard limitations for employment assistance and employment support are just a smidge different than the habilitative services, still, they cannot be authorized in combination with another service and offered during the same time. Transportation's not included. Along with the school disclaimer for school-aged folks, this is also a service that cannot be provided during, for example, voc rehab time. It's the IDEA, and that is essentially voc rehab here in the state of Nebraska. So employment support has to be provided in the community on the job site. The focus would be work appropriate behaviors, time management, job tasks, maybe even social skills. But this is something that is meant to be provided on the job site. So it's another opportunity to keep the individual connected to the employment relationships they might have already had. And that, of course, is dependent on the nature and reason of the admission. You know, obviously, if there was a hip replacement or a knee replacement, they may not be going to their community job or, you know, whatever, just due to the medical condition. The limitations, very similar to the employment assistance. One extra is that this particular service excludes supervisory activities. So that's important to keep in mind. And then you see the same standard disclaimers. The non-medical transportation is billed separately. This is basically for getting one of the folks from the nursing facility to wherever they're going and then back. They have to be present in the car, and of course it doesn't really cover purchase or lease of vehicles. So all specialized add-on services for folks with IDRC is going to be prior authorized through our unit here in Medicaid. I will definitely include contact information at the end of this, and I just want to make sure that everybody understands that it's a learning experience and curve for us as well as for the nursing facilities and for the community-based providers that'll be providing these services. Basically, the prior authorization is going to be one prior auth for each separate service. The agency that is sending in the prior auth needs to specify the formal goals and objectives that are going to be used and the frequency and duration. And then with this prior auth, we need to have a copy of the level 2 PASRR. So the nursing facility is responsible for providing that to the DD provider, and it needs to accompany this prior authorization request. It's only valid when there are specialized add-on services recommended by the level 2 PASRR. And the nursing facility, when they have these services recommended, they are responsible for putting those in the nursing facility plan of care. And they have to track those. So that's why there's prior authorization, and we want the DD providers to be an active part of that team at the nursing facility. This is where you can find the prior authorization form. Basically, go to that website. In there's a search bar. Just search MLTC-78, and that form will pop right up. It is a fillable form, so you can print it and fill it out. You can do save as, download, and fill it out electronically, and then submit it to us electronically. It's basically whatever works best for the community provider. Payments go to the provider of the services. So basically, once the services are prior authorized and the community-based staff are starting to work with the resident and provide the services, then the claims need to be submitted, not through NFocus. We have these claims coming through Medicaid, through the fee-for-service program. It's called Medicaid Management Information System. We refer to it as MMIS. The claim form that is going to be used is the CMS 1500 claim form. It is a professional claim form. And then the electronic data interchange with Medicaid, you can find at that information at that web address there at the bottom of slide 37. The claim form itself, that CMS 1500, you can submit it electronically or you can submit it via paper. This slide has a couple of websites that you can get a sample of a claim form. You can also get general information at the other website. You can download a reference instruction manual just basically by going to that website and then clicking in the downloads kind of towards the bottom of the page. The claims are available for purchase through vendors such as Staples or Amazon. There's also a phone number where you can just order them from the U.S. government printing office. I basically did a Google and found, Staples, Amazon, and a few others that I just didn't put down. So provider enrollment. All of the community-based providers, while they may be enrolled as Medicaid providers through our provider enrollment unit and through Maximus, the issue is we need to have an additional group enrollment. So I think you can contact Maximus and ask for assistance and basically update what your current provider agreement is, or maybe use it to just, unfortunately, I'm not provider enrollment, so not my expertise. However, like I said earlier, very willing to provide guidance. Our info will be at the end of this presentation. It's a learning curve. Trust me, I understand. And with our targeted go live date of May 1st, in order to do that enrollment, Maximus will be ready on about April 28th. So I don't think we're going to see a lot of like influx of services right off the bat. I think it will take a little bit to get used to and work out the kinks, but we do have a go live date of May 1, and that is right around the corner. Every agency typically already has a national provider identifier or an MPI. In order to be an enrolled Medicaid provider, you do have to have that. So this is the website. The reason this is included here is Maximus and Medicaid are implementing a new best practice. Every staff who works for an agency and provides specialized add-on services, they will also need to have their own MPI number. You can apply for the MPI at the web address at the bottom of this slide. It truly takes about 10 or 20 minutes, and from what I understand, you should receive it within a day or two. So in order to complete billing on that CMS 1500 claim form, not only will the rendering provider, which is the agency, they'll have to have their national MPI, but then also their staff that are working with the individuals, they will also have to have an MPI. And unfortunately, there are no questions to ask because we are just recording this. But here is the contact information for myself and for Greg Carlson. Greg is our program specialist for nursing facilities. I'm the program manager too for nursing facilities, amongst other things. And our general email box is dhhs.mltc institutionalservices@nebraska.gov. So you can either email us directly, you can email the shared mailbox. It is monitored a couple times a day, and that way you have it. This slide is included so that you can find the helpful information that we feel is helpful in the Medicaid public website. For provider information, that's probably the most important since provider enrollment is not my specialty. Lots of good information on the provider information page. Provider bulletins, that's the website. We post provider bulletins. There will be a provider bulletin posted for the specialized add-on services. And then for regulations, we fall under the 471 Nebraska Administrative Code in Chapter 12. So that is all I had for today. I do thank you for your time. Please do not hesitate to contact myself, or Greg. If you have questions, we do have a go live date of May 1st. I just want to reiterate that we are here to answer any questions. We understand it's a learning curve. It is for us also. So I just want to thank everybody for their time and for everything they do for our folks in service. Thank you.